Can you see it?
Yes.
Beautiful.
Good morning, everyone, and welcome to today's webinar, Structural Barriers and Substance Use Disorder Care Among Hispanic Populations, Means, Strategies, and Resources to Improve Access and Services. We are also very grateful to be joined today by our speaker, Dr. Hector Colon Rivera, who will be discussing and sharing insights on this topic, one of much importance for advancing behavioral health equity among Hispanic and Latina communities. My name is Eric Senior. I'm the Training and Technical Assistance Manager for our center, the Hispanic and Latino Behavioral Health Center of Excellence. If we can move on to the next slide, please, Dr. Colon. So we are offering simultaneous translation to Spanish as part of today's webinar. To hear today's presentation in Spanish, please go to Interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice by clicking Mute Original Audio. So, así que para escuchar la presentación de hoy en español, pueden presionar la pestaña de interpretación en el panel de Zoom y luego presionar español. Next slide, please. So just a few housekeeping items before we begin today. Today's event is being recorded and all participants will be muted and cameras turned off. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having any technical issues, please send a message to either myself or anyone under the name of Hispanic and Latina Behavioral Health COE on the chat box. If you have any questions for our presenter, Dr. Colon, we ask that you use the Q&A tab on the toolbar and type your questions and hit send, and we can address those questions to our presenter at the appropriate time during today's presentation or at its conclusion. We'll be sharing a copy of today's presentation in PDF format through the chat box. And once we complete the webinar, please complete the evaluation. This is very important for us to get your feedback and your input to this training and to be able to advance and implement other trainings in the future. So a link to the evaluation will be shared through the chat towards the end of the presentation. You can also scan the QR code that we'll share at the end of the presentation to complete it. You will receive a certificate of attendance by email approximately 2 weeks from today. So please remember to check your junk folder because it sometimes ends up there. And so as the Hispanic and Latino Behavioral Health Center of Excellence, our mission is to advance and support the sustainability of behavioral health equity by promoting community-driven, culturally grounded, and person-centered prevention, intervention, multiple pathways of recovery, and recovery supports for diverse Hispanic and Latina communities. And we would like to note as well that the Hispanic and Latino Behavioral Health Center of Excellence recognizes the complexities associated with gender and ethnic identification, as well as the right of all individuals to self-identify. The center uses the term Latine with the intention of both facilitating a fluent reading and pronunciation and supporting inclusive and respectful language. Latina is a gender-neutral form of the word Latino that uses the letter E at the end, an idea native to Spanish language. And so now I would like to hand it off to today's speaker, Dr. Hector Colon Rivera. Thank you so much for having the time to present and share today.
Thank you for the invitation, and welcome all. I see that it's almost 130 participants in this webinar, so thank you for joining us. My name is Dr. Colon Rivera. I'm a psychiatrist. I'm board certified on adolescent psychiatry, addiction medicine, addiction psychiatry, and of course, general psychiatry and neurology. So I work for the Asociación Puertorriqueños en Marcha, which is a nonprofit here in Philadelphia. I also am a consultant for DDAP, the Department of Drug and Alcohol here in Pennsylvania, and I work for University of Pittsburgh as a telemedicine site provider. I'm a volunteer faculty of Western Psych at Pittsburgh. So in terms of conflicts, I had no conflicts other than I'm really invested in the Hispanic community, and I would love to hear from you guys. I mean, the chat is pretty busy, so I mean, you can put the question there. If I see that, I will try to answer it while I'm speaking. If not, we'll have a Q&A at the end. And so some of my employers are APM, which is Asociación Puertorriqueña de Marcha, and University of Pittsburgh Medical Center. Our objective for today is to discuss the structural level of barriers that impact substance use disorders, care services, access, and outcomes for Hispanic and Latin communities. Also a little bit about mental health, since both mental health and substance disorder usually walk hand by hand. Depending on the state, right, we had different pathways in terms of coverage for these services. I saw some people are here in Pennsylvania, so hi to people here in Pennsylvania and my neighbors. And probably it's the same in other states that we have two pathways. One, DDAP, which is Department of Drug and Alcohol, and the other depends on the county you live in. The coverage is different. A second objective for today is to address models, programs, and resources that helps improve the access for cultural grounded and responsive substance use disorder care services for Hispanics. Discuss means, strategies, and recommendation to develop and implement advocacy initiative and connect individuals in the community-based support. And happy to hear from you guys what's going on in your states as well. I will talk a little bit about, of course, what I'm more knowledgeable about, which is the state of Pennsylvania and Puerto Rico. So a little bit of background. I mean, culture and health, they were not friends in the past. I mean, it started to, the general surgeon and the politicians in the states started recognize this back at the end of the 1990s. So the first time that it was, they realized or report about it, it was in 1999, where the Surgeon General released a mental health report, reporting that they acknowledge that not all Americans, especially minorities, receive equal mental health treatment. And then a supplement was published on 2001, and they cleared the measures of cultural counts in terms of treatment. And just to make clear what culture is just the belief, norms, and values, and language that all play a key role in how people perceive and experience mental illness or health in general. So to be effective and to serve Americans and Hispanic communities, we need to recognize that and understand and respect cultural differences. So it's really important. Also, I mean, the forecast of the Hispanic population in the United States from 2022 to 2060, this is in millions. I mean, we see how, right, this is increasing, and it's projected that 28.6% of the total U.S. population and 33.5% of children will be Hispanic. So we're talking about 1/3 of the population will be Hispanic by 2060. So I hope most of us are alive to see that in 2060, but that's a big number. And when you think about how many health professionals are Hispanic or understand the culture, I mean, we're talking about probably less than 4% of the health professionals living in the U.S. or working in the U.S. and actively working in the U.S. Because, I mean, some of them have been close to retirement. That's a pretty bad, misalignment between what the population and the demand for services is versus the offer of the services in the United States. Demographic and societal issues according to the census, the Hispanic population in the United States is expected to grow to 26%. We talk about that, and it upped from 19%. Here in Philadelphia, for example, we are almost 18% of the Hispanic population. And probably, we have states like California, Texas, Florida, New York is pretty high as well. We know that 59% of the U.S. Hispanic people have a Mexican background, followed by a Puerto Rican background, which is close to 10%. 19% of Latin Hispanic people in the U.S. live in poverty. So that's, when we talk about barriers, that's a big barrier. And they're highly concentrated in few states in the U.S. I mentioned a few of them, like California, New York, Texas, and Philadelphia, and Pennsylvania. You will be surprised. I mean, I do some talks for Minnesota, and Minnesota population is increasing pretty fast. Also, people in Michigan, Ohio, that have been contacting me for presentations. Is the Hispanic population is increasing in a pretty fast pace. There is a perception that Hispanic community, especially among older people, that there's a lot of embarrassment, stigma around, and shame around mental health issues, and I think that plays a big role on how they perceive mental illness and why they take so long to look for help. I think that perspective is changing a little bit with the new generations, but still there. Immigrant health in the U.S., Latino immigrants in the U.S. are healthier than their U.S.-born Latino and non-Latino counterparts, which is really important, right? And when we talk about substance use disorders, usually people that move from Hispanic country or immigrate to the U.S. and keeps their values, their norms, their language, have more protection and less risk factors to have a mental illness or a substance use disorder than those that are born here or those that move here and don't keep these traditions and their culture. So that's key. That's why it's really important to, when you offer treatment, to offer in a cultural context and also have people that represent them, not only that speaks the language, but also culturally represent the people you are serving. So there is a lot of, that's due to the stress with being in a Hispanic immigrant and in the US. So just being an immigrant, just by being an immigrant, you have a lot of risk factors. So it's something to think about. Progress and priority of this is a health credit report of Hispanics, and it's just a study that tests and look the data and measure the data behind different diagnoses, including substance use disorders and mental health, but also cancer, cardiovascular disease, and diabetes, and which are all chronic diseases that most of the Hispanics suffer from. They also check for suicide prevention and mental health care. And we see how the trend is going. So we have done a lot of improvements on cancer and cardiovascular diseases. However, and same with diabetes. However, with suicide prevention, mental health, infant mortality, and care, they're a little bit lower. But if you can see on the screen, suicide prevention and mental health care is worsening. And disparity change is 0%, so we're not doing a good job on this. This was back in 2018, and probably still the same. So suicide prevention and mental health care is not great for Hispanic community here in the U.S. And if you read about it, you can just Google or search, Hispanic clinics, for example, and you see how they are closing out most of the Hispanic clinics around different states. And only a few states have open Hispanic clinics that includes substance use disorder treatments and mental health treatments. Past year substance use disorders, and these are disorders. For information, disorder is someone that meet the DSM-5 criteria for disorder. It has to be using for more than 12 months and meet at least 2 out of 11 criteria to meet criteria for a substance disorders, and about 8.9 million Hispanic people, in that 17%, has been diagnosed with a substance disorder. And the first one is, the most common is alcohol use disorder. Drug use disorder is followed by drug use disorder, and that could be, in general, any substance use. Interesting, because if you search again for information, marijuana or cannabis is the drug that they use the most, and Hispanic use the most. However, they're not meeting the criteria for a substance disorder. Only 7% are meeting the criteria for a substance disorder, for a marijuana use disorder. And alcohol, even though it's not the most used, probably, followed by, it's the one that follows the marijuana use, is the one that is creating the most issues in the Hispanic communities, and the one that people are meeting the criteria for a disorder. So alcohol use disorder, people use chronically, they causing more issues, health issues, probably creating more withdrawal symptoms, more tolerance, and more societal issues for Hispanic communities than other drugs. Heroin is only 0.2%, and cocaine is only 0.5%. It's really hard to find someone that's just using cocaine and is meeting criteria for cocaine disorder. Usually, they're using multiple drugs, and you can have people that are diagnosed with 2 or 3 substance use disorders. Alcohol, cocaine, people use, pretty common to have both. And also, the opioid use disorder, stimulants, is pretty common. And we have seen more people using meth, which is a stimulant, and of course, instead of heroin, using other types of opioids like the fentanyl, and now adding with the xylazine or the tranks. We're seeing that, and it's something that was not count on this research back in 2022. There are a few differences when we see different groups of Hispanic, and when a problem that we see in these studies is like Hispanic Americans are often studied as a single population, and usually, we are pretty differences. We have a lot of differences. And this study back in 2012 it shows that we are, even though we are all Hispanic groups, there is a lot of subgroups, and that includes Puerto Rican and people from Mexico, Cuba, Central America, and South America. So few differences in the strain. So Puerto Rican have the highest rate of recent illicit drug use, and South American have the lowest. Puerto Rican have the highest rate of recent marijuana use, while Cubans and South Americans have the lowest. And individuals originating from the Spanish-speaking country other than Puerto Rico, Mexico, Cuba, Central America, and South America have the highest rate of recent cocaine use, while Cubans have the lowest. So again, just to show you that, subgroups, if you divide Hispanics in subgroups, you will see a difference on the type and the preference of drugs they use. And probably you will see a difference in substance use disorders and probably a treatment availability for those populations. This is an important slide here. We know that nearly all Hispanic people with a substance use disorder who did not receive substance use treatment did not think they needed treatment. So again, this is about perspective. People look for help when as an addiction psychiatrist, I see a lot of people that look for help when it's too late sometimes, or they have lost everything. They're homeless. They have a bunch of legal issues. They have lost their families. They have chronic diseases like Hep C, HIV. Then they look for help. Prevention is. We don't do a lot of prevention, and we think a lot about treatment, but prevention is something that we don't think about too much, and that need to change. And of course, we need to educate our Hispanic communities that looking for help earlier is better. But again, we need to treat stigma, we need to treat the shame and the usually the denial of our communities having a substance disorder, especially with drugs like cannabis and marijuana, which is probably acceptable in our communities. And now with the movement of states, accepting recreational marijuana or marijuana for medical purposes is getting harder to educate people on the risk of using cannabis or marijuana. And of course, alcohol disorder. I mean, for Puerto Ricans, we start drinking at the age of 18. That changing, they moved to US, which is 21. But other countries, Central America is also 18, and legally drinking age is 18. So that create a difference in how people, when people start and how long they have been drinking, and the likelihood of creating an alcohol disorder in the future. Latinos 12 years and older who did not receive mental health or substance use treatment in the past year. So again, I mean, a lot of people, especially those with serious mental illnesses, I mean, 18 plus, we're talking about no treatment is 41%. And those that have more than one drug use is at 55%. And a major depressive disorder, which is pretty common, probably the most common, outside anxiety disorders in terms of, mental health, mental illnesses in the Hispanic communities, which is depression and anxiety are the most common. It's only about 30% receive treatment out of the 100. So we're talking about 3 out of 10 people receive treatment for those. And we go back to this survey back in 2021, and we see again, I mean, how disparities have worsened and or no change, or even it's getting worse. I mean, interesting data here is that suicide death per 100,000 population is better and is narrowing the disparities. So that's good. And I know there is a lot of more resources in terms of suicide. There have been more announcement and marketing of resources like some of the chats that we have now, the 911 versus the 9AA option that you can chat. NAMI and other organizations have options online that you can go to the website and have someone there to talk to. Social media has created some algorithm that they identify when people having a conversation about suicide. They can be is a red flag for the social media, and sometimes they send resources or flag that conversation. So a lot going on. I mean, but in general, services have been decreasing and not increasing for Hispanic communities. Is it difficult? Yes. Impossible? And no. But we need to treat these barriers. So let's talk a little bit more about these barriers and how we can decrease them, right? We can do something about them. So Latinx, Hispanic people are more likely to seek help for a mental health disorder from a primary care provider. So that's about 10% than a mental health specialist. So that's about half of the people. Poor communication with healthcare providers is often an issue. So they do, find comfort on their primary care physicians. I mean, they do trust the primary care physician. And usually the primary care physician do a good job, right? It does a good job screening for a mental illness, especially if it's depression or anxiety. They're getting better in the last years on screening for substance disorders as well. I think tobacco use have decreased enormously. I mean, because of the marketing that the health professionals have done and other organizations have done. but we still need a lot of research and data and work to do with other substances, especially opioids, cocaine, alcohol, and cannabis. Mental health problems can be hard to identify because Latinx and Hispanic people will often focus on physical symptoms and not psychiatric symptoms during a doctor visit. An example could be, when people are withdrawing, people are chronically using alcohol, they complain about memory issues, stomach ache, right? Maybe tremors, feeling tired, not sleeping, so insomnia, more than, hey, I have a alcohol problem or drinking too much. Usually primary cares don't do urine tox screens, and it's harder to identify any substance use. But it's really important to ask the question, when was the last time you have a drink? And during that time, how many drinks you have? So if you're using the NIAAA questions, 7 for females during a week, 14 for males during a week, depending on the age, it is 65 plus, it doesn't matter if it's male versus female, 7 or more is a red flag for problematic drinking. So that's important. We don't want the client to complain about stomach ache and tremors and things like that, and having cirrhosis, stage 4 cirrhosis or hepatic renal failure due to the chronic drinking. And it happens. It happens on my clinic when someone complaining alcohol disorder, they already have cirrhosis. They already have a terminal illness, and they're dying. And it's really hard to treat. So we need to do a better job screening when we start. When patients start complaining about these symptoms, or screening even before, the problematic alcohol drinking becomes an alcohol use disorder. In terms of societal issues or risk, we have poverty rates of Hispanic Americans is nearly 2 times higher than non-Hispanic white Americans. We're talking about 17% versus a 9%. So yes, we work really hard. Sometimes we have 3-4 jobs, and still, our finances or our patients are not the best, the greatest. So that's something to take under consideration in terms of barriers. Some people don't have the transportation, the money for transportation. Good thing about telemedicine, telehealth. So if you have that increased access. But then we have the problem that most of my clients, for example, don't have a smartphone, right? So they cannot connect by using telemedicine and telehealth. COVID changed a little bit that. COVID-19 changed that, and some states and the federal government, kind of loosened some of the regulation they had before in terms of telemedicine and telehealth, and that's still, in the work. But we need to use technology, and technology is a good way of accessing and getting treatment to our Hispanic communities. And you can use, if you don't speak the language, you can. There's a lot of interpreter and translation services out there that use AI to help with the language. And of course, there's a lot of companies that promote and can guide you in terms of using telemedicine. There's a lot of Medicaid usually pay for telehealth telemedicine visits. So use that. So I don't know what the future is gonna bring, but for now it's looking good in terms of approving the use of telemedicine, telehealth in the future. And we have about 18% of Hispanic Americans were not covered by health insurance, which is another issue. In our nonprofit, we have grants for people without insurances, and we also have a grant for undocumented immigrants to be able to do services for them while they get insurance, of course. So just a friend of mine, Augusto, and Augusto is an adolescent that I saw probably about 2 weeks ago. He's 17, and Augusto is a pretty, I would say, has a common presentation for someone that had a substance disorder and a mental illness. and kind of lack of support from the family as well. So he's 17, Spanish speaking from Puerto Rico, who lived with his mother. Then moved to Philadelphia after Hurricane Maria destroyed their home. It's pretty common back in 27, so in 17, and then the earthquakes and all that, destruction. A lot of families moved to Philadelphia or other states and looking for housing. They moved without insurance, most of them, without school preparation or jobs. They just move, escaping that reality that were having in Puerto Rico. Um, and Augusto have a history of trauma, which is not uncommon, right? To have history of trauma. And I mean, I'm pretty sure you guys have heard that the ACEs before, the adverse childhood events, the scales, that the more you have, the higher risk you have to have a mental illness, a cardiovascular disease, the suicide risk, and drug use, between others, chronic medical issues. So, so again, Augusto have probably multiple adverse childhood events, including a father that was physically abused over him, and also living, right? So a lot of neglected. I mean, he was neglected by parents. Augusto has been using heroin, cannabis, and cocaine for the last 2 years to calm his nerves. So he's been self-medicating, which is not uncommon for kids or anyone with a mental illness. And usually about 70%, I would say 60, between 70% of substance use disorder are preceded by mental illness. So we have depression, anxiety, and people try to self-medicate with drugs, with illicit drugs, and that you know put them on a higher risk of having a substance disorder, especially if they start before the age of 14. I mean, studies say that if you start before the age of 14, using a substance use, of having a substance use before the age of 14, the likelihood of having a drug use disorder is a lot higher. So Augusto presented to my office, now receiving psychotherapy and medication, has stopped using cannabis and cocaine, but continues to use heroin and probably fentanyl, right, at this point. He has tried buprenorphine for opioid use, but it has not worked for him. And at times, he sells his medication. So it's not uncommon to see that. I mean, MATs, it doesn't matter if you're on buprenorphine or methadone. I mean, there are some people that share them or sell them or give them away, on the community. So something to monitor and be aware of. He missed his last appointment, and you found out that his mother, told him to leave the house, and he is now kind of homeless or with people around, and his girlfriend is pregnant. Okay, some observations are he speak only Spanish, substance use, pregnant girlfriend, his history of trauma, possible homelessness, and missing appointment and school. So when we talk about risk factors, I mean, those are pretty significant risk factors. So when you are, writing your assessment, I think, these risk factors put him at high risk of suicide or overdosing, unintentional overdose, or other situations that we need to prevent. So when we talk about what treatment is, I mean, especially for Augusto or people like Augusto, it has to be safe, it has to be effective, it has to be culturally humble and sensitive. It has to be patient-centered, and they have changed through the years. I mean, before it was pretty paternalistic. I mean, the doctors say, kind of order you to do this and you need to follow. Now it's more patient-centered. It has to be timely. I mean, when talking about Augusto, 17 years old, homeless, missing school, missing, not working and things like that, and not having a lot of support, has to be timely. It has to be efficient and equitable. So again, he has no insurance, and it's we see here 2013, 2018, a little bit of improvement, but still Hispanic has the highest, no coverage for insurance. And of course, it gets worse, I guess. I mean, I as an adolescent psychiatrist, I think the youth is a higher risk. And again, you can search this and Google it. I mean, adolescents are going through a lot of, I guess, mental illness in adolescence is not improving, it's worsening. And we see a lot of news around adolescent psychiatry and adolescents using substances and dropping out and not finding treatment. And there is a lot of reasons for that. I mean, one of the barriers is not communicating with, when the transition between, when they call the transition of youth, or the transition in ages, when you are going to from being a pediatric patient to a primary care physician or internalist or family physician, there's a gap there, and people drop treatment. So we need to do something about it. I don't know what the solution is. I mean, you guys have a solution for that, but I think communication and warm hand off, kind of giving the patient the meeting the pediatrician with internal medicine or family medicine, having that conversation, and just I would say transitioning the patient to the next physician or health professional. I think that will be useful, and it will prevent people from dropping out of treatment. But by the age of 12, I mean, by the 12th grade, sorry, by the 12, Latino students report a highest rate of 30 days use of marijuana, inhalant, ecstasy, cocaine, crack, vicodin, methamphetamine, crystal meth. I mean, you name it. Cough medicine is a big one, and tobacco use, hookah, right, or e-cigarettes. That's another topic. E-cigarettes is a pretty big deal for adolescents. They usually say no. If you ask them if you're smoking, they say no. But of course, they're using e-cigarettes and electronic cigarettes pretty often. Past studies have shown that Latino students have the highest rate of binge and heavy drinking. That's pretty common in college students or high school students in 11th, 12th grade. I've seen that. And Latinas, adolescent teenager pregnancy rates are higher than any other racial and ethnicity minority groups in the adolescents. We see this. I'm from Vieques, Puerto Rico. I mean, we see how in Vieques, I mean, we have a really high rate of pregnancy. Also, I mean, with pregnancy comes other situations when you have a lot of sexual transmitted diseases like chlamydia, for example, is pretty common. Whenever you have a high rate of pregnancy or stay with that or a county with that or a place with this kind of rates, you will see that followed by STDs rates, right? Like chlamydia was a big deal in Vieques and still is, and it's a health problem and public health situation for Vieques. More known risk factors: a family history of alcoholism and parental use of illegal drugs, poor family management practices, academic failure, and we see this in Augusto example. But once you have a patient with substance disorder and mental illness, we need to find or look for this risk factor, putting a higher risk of overdosing and dying or suicide. The earliest they use a drug use, we talk about. I mean, if it's before 14, it's a big deal, and after 14, we see probably still risky, but less risky than having someone that started before the 14 years old. And extreme economic deprivation and neighborhood disorganization are other risk factors. And I want to present the barriers to care in 3 levels. I think it's easier to visualize the levels of care and barriers in 3 levels, which this would be the individual level, which is the personal one, the communal level, and societal barriers. And I think I like this division because you can actually, see the zoom in and zoom out of barriers for patients and the community. So when we talk about individual barriers, stigma is a big deal, and I know people are talking about stigma on the chat. Cultural barriers, we talk about that. Masculinity is a big deal. The macho man, the Hispanic community. I mean, the machismo is pretty prevalent. And violence and trauma. I mean, the shootings, the gun violence is increasing in our communities, and kids are killing kids in our community. We see that on the news all the time. That's why I don't watch news every day, because it's a trauma to watch news and see what's happening in our communities. But of course, we need to be aware of that, and advocate for a change. Lack of knowledge and awareness, that goes with hand to hand with education and having prevention services and prevention talks in schools about gun violence, substance use, abstinence, and we're talking about sexual education and things like that, or protection, right? Using protection when having sex are very important topics to talk on high school and even earlier than that. So other barriers are shortage of cultural and linguistic appropriate services. We talked about this in the beginning. We compare, right? We're moving towards a 33% Hispanic population by 2060. And we're seeing how health professionals have been decreasing or kind of stuck on the 3 to 4%. So that's not moving up. It's not moving down either, but it's kind of stuck on that, between the 3-4%. And we're talking about social workers, doctors, nurses, physician assistant, you name it. I mean, it doesn't change much and stay the same. A shortage of qualified mental health professionals. That's what we're talking about right now. A shortage of academic and school-based mental health programs. There's a shortage for that. And structural barriers to care. That's increasing. I mean, less people treating or specializing in Hispanics is happening, and they're closing clinics around our country. And when we talk about social barriers, we talk about the economic resources and living condition of our society, inadequate transportation, social exclusions, accessibility, the critical shortage of mental health facilities and general practitioners and specialized providers in our area. We can talk about legal status and the fear of deportation when you have someone, an immigrant, and that prevent them from seeking help. I mean, it's really scary to go to a clinic, and when they ask you for ID or they ask you for proof of employment or a proof of health insurance, that's book people. I mean, I struggle with that on my clinic when the front desk personnel asks the client that's approaching the front desk asking for help, right? And they ask for this paper. That it's kind of scary for some of them. And people don't have insurance for different reasons. I mean, I saw that on the chat. I mean, they are just moving to the U.S. I mean, that requires a lot of paperwork and knowledge about, where to apply, how to apply to health insurances. People usually work. There are some people that work under the table, so there is no insurance link to an employer, and that's another issue. Some people are afraid of being on Social Security and receiving benefit from that state, and also linking that with a health insurance. And some people don't have the education to go through the application of having a health insurance. Some people forget to renew. I mean, they have health insurance for a year or two, and they renew. I mean, that happened during COVID-19. I mean, a lot of people, because the state stopped asking for renewing the health insurance to prevent people from dropping out while the pandemic was happening. Also, the closing of different agencies. So they allow people to having health insurance in a continue And then when they dropped that, a lot of people lost health insurances, the health insurances. So, and it gets worse when you're 65 plus and Medicare. Medicare is super confusing uh, for people that don't understand the topic. Even for providers, it's super confusing. One day you get a letter, you have a few months to change health insurance, you Medicaid to Medicare, and it changed. Then they put you in a situation when you need to decide when you didn't have to decide before. Now you have to decide what Medicare you want and forget about it when they are asking for Advantage package and things like that, coverage for your eyes, coverage for your dental health, and now you're talking about premiums and co-payments. It's really complicated. I mean, the health system is really complicated. And forget about calling Medicare. It's hard. No comments there, but try to call Medicare and get someone to help you, especially in Spanish. Good luck. Okay. And of course, we have the issue with the culture and the stigma that people may not seek for treatment because they may not recognize the signs and symptoms of mental health conditions. Is there as well. Um, so So when we talk about treatment, and this is really important, right? We need to have treatment available in a culturally relevant service. I'm not only talking about speaking the language, and I will keep saying this, speaking the language is not enough for people to feel comfortable or attract clients or attract the patients and to stay on your services. Yes, they might go one time for the intake and they don't show again because they don't feel welcome sometimes. I mean, and it helps that their provider not only speak the language, but also look like them and they feel comfortable with that. I always, my nonprofit, I always talk about customer service and customer service is, and I say that, I mean, maybe it's sounding, but customer service is really important. You need to show, we need to care for that clients, and we might not see them again. I mean, that first introduction, receiving the right information, especially about healthcare and the cost of services and things like that, that can scare someone and don't come back. If they're not receiving, we need to have, our material in Spanish and English. In both languages. Our intake package has to be on both languages for people to feel comfortable with that. If we have a provider or a therapist that doesn't speak the language, we have services right there for them that can interpret in their language, and so they feel comfortable. So has to be a mutual trust. I mean, it's patient-centered, but the patient need to trust their provider, and that starts with the front desk. That starts with the people in front of the clinic. Not only the doctor, the nurses, the PAs. It has to start. Every staff member has to be on the same page. We're talking about customer services and welcoming the patient. Speaking the client language is crucial for mental health treatment, especially if you're doing therapy. If you tell me you're doing therapy and you don't speak Spanish with a Hispanic patient, I mean that you're not doing therapy. I mean that's impossible. So and and uh, and it's tricky, right? I can talk about this for forever, but in the state of Pennsylvania, we have an issue of we don't have. I mean, we have some companies saying that they have interpreter services and they see Hispanic communities, but they don't have any of the staff. I mean, no staff speak the language or are cultural competent to treat Hispanic communities. So that's a big issue. So we need more bilingual services in the nation. I mean, in general, many immigrants experience discomfort discussing mental health problems with a therapist. That's true. I mean, it takes time. It takes time to create that rapport. So how, I mean, I talk a lot about the problem. So how do we improve community services and treatment? Um, so prevention and early intervention, evidence-based community is really important for improving substance use disorder treatment. So we need to create a structure that not only the doctor is available, as I say, I mean, it has to be the staff, has to be diverse and culturally humble. And we have a peer support and mentoring program. So if I have for example, I have psychiatrists that are bilingual, but no Hispanics, and I have doctors that are Hispanic, but they're not that cultural humble. So we created a program that is a peer-peer support. So we meet once a month. We talk about cases, and we talk about the best way, evidence-based way of culturally treating this patient. So that's important. I mean, meeting with your staff and talking about cases and sharing ideas and sharing, why the patient reacted this way when I say this, or didn't react when I say that, is really important. I mean, family psychoeducational curriculum is really important too. So including the family. Again, as a psychiatrist, community psychiatrist, I see different generations. I have the grandma, I have the baby, I have the kid, I have the mom, the dad, and different generations, different ways of talking to the patients. But including the family is really important. You can have a family that only one speak English and the rest do not speak English. So that family-based treatment, that family-based appointment has to be in Spanish, and you need to be able to, culturally and linguistic, be able to do that. So prepare for that encounter. Have someone, if you don't speak the language, have someone that they do, and someone that is trained on doing that, not someone that is a friend of the family, or is a family member, or is a staff that speak the language. No, it has to be an interpreter, and probably have a license to be an interpreter if you don't speak the language. So that's really key, to have that kind of people on your team, or use a teleservice that, or call an interpreter line to do that. And that will help to increase your capacity building strategies, and promote a connection and community-based strengths. Knowing, showing to the community that you have access to these resources. Trust me, they will trust you, and they will come to your services. Academic and school-based mental health programs is really important. In the nonprofit, we have different departments that include housing, foster homes, and we have schools. We try to that these departments are no like solos, and they don't work in the. I mean, we need to create a communication between departments so we can refer to each other and have that community, intra communication with different departments, so we can present the resources for this patient. I mean, remember that patients are not a chief complaint. They do come with a complaint, but they have different problems at different levels. I mean, we're talking about finances, we're talking about housing, and of course, education. We're talking to a child, a kid. So we need to, take all that under consideration. And when you have a staff, and someone is asking me for a referral, and someone, out of network or outside the nonprofit, it's really important to find someone that have probably experienced treating Hispanic and Latinx, or have a training and cultural competence, or and mental health, and or have used any training. I mean, nowadays, because of the diversity, equity, and inclusion movement, I mean, most health systems have training on these topics, and so that's good. How serious the training is and how serious people take it, that's a different question, maybe a topic for another conversation. Because you have people that just move forward with this type of trainings, but it's good that they're presenting this, and you have the option of being trained on this. So when you are referring someone outside your network, it's really important to touch base on what kind of training they have, if they have experience treating Hispanic community. And you know, I mean, I offered my patients to ask these questions before they go to their appointments, and ask them, you know, if they have the experience treating Hispanics in the past. And when I meet with residents or fellows and do the teaching classes and stuff like that, I I I do promote this, that they're trained on cultural background, that they read about it before they meet with the patient. Because I mean, there are a lot of mental health. You're gonna see, you know, the diagnosis of you know, it can change drastically. I mean, data say that Hispanic and African Americans are diagnosed with, you know, psychosis and bipolar disorders the most because of miscommunication or mismanagement of or misunderstanding of symptoms and signs of the disorder. I mean, usually, you know, I have seen a lot of misdiagnosis on Hispanic and African Americans just by the way they talk, the way they present, the mannerisms, and things like that, or the cultural background, the cultural beliefs they have. Um, so a few models that I will recommend for you guys to use when you're dealing with these issues and you're seeing a lot of barriers. Um, there's a lot of frameworks that are pretty good. I mean, the model of stress and coping is a good framework for understanding the acculturation process. And, and of course, acculturation can itself produce a lot of stressful life event associated with poor mental health and substance and alcohol use. And we see this a lot of in adolescents, right? When the family move to a different country and the kids come along, and they change, of course, they change schools, uh, and the question of, you know, missing one grade or going, you know, to a different grade comes in, or, you know, IEPs or special education topics come in, and it's only because the language is a barrier for some of these kids, and they're, you know, they feel a lot of stress, distress, because they cannot communicate, and they kind of, you know, feel that they cannot manage school at that level. So that's just an example of how you know, immigrants are affected when they move in terms of education. Education is a factor, but this kind of models, stress illness framework, it helps you know, you to acculturate and fill in the gaps and help understanding mental health, behavior problems, and of course suicidal thoughts because they're stressed. Um, there's a good model. It's called Familia Adelante. And of course, you can search this. There's a good website. And actually, you can join some of the trainings they have. And Familia Adelante is a multi-risk reduction behavioral health prevention for Hispanic and their families. It was developed back in '92 as a framework for stress management, coping skills, and family resiliency. And it helps to strengthen the ethnic identity and sense belonging of the participants, and target the various combination of culturally based stressors and other you know, signs and symptoms of mental illness uh, that are directly you know, that directly involve Hispanic stress in terms of, you know, moving to a new country. Oops, sorry. Okay. Um, So that's a great example, and it's a pretty nice curriculum what they have. And the curriculum educates high-risk Latino youth, usually between the ages of 10 to 14, includes their parents and includes their family. Also have a lot of, they talk about a lot of about harm reduction and risky behaviors and increase positive engagement in school. Uh, I think it's based on 12 sessions that you can have, and they have an in-person curriculum and a shorter version online. That's about 8 sections that you can take. So a pretty good program. So I really recommend it. It's a good model. And of course, there has been a good movement, a pretty decent movement on integration and behavioral health. Those of you guys that work with the VA, the Veteran Affairs hospitals or clinics, you see this a lot, that there's a team that's integrated with primary care, and you can make consult to behavioral health, and you have someone that actually join you on that visit with the patient, and sometimes serve as a handoff for behavioral health. So in that moment, you present the person that is going to take care of you in the future for your behavioral health issues, but also work as a consult. If the patient doesn't need to go to a psychiatrist or a therapist, it helps to identify any risk in the moment so the primary care physician can take care of it. So pretty good model, and it does take a lot of structure for the clinic that is implementing it, but I mean it's covered by some insurance, and I think it's the future of behavioral health. I think that is most needed. I think the VA has the best model that I know of, and he has been studied by the VA. I mean, in other health systems, and it does improve population health, improve experience of care, and it does help with the cost curve and improve provider satisfaction. So again, it doesn't get better than that. I mean, if you have the patient satisfaction and provider satisfaction in the same sentence, I mean, it's a no-brainer. So another, yeah. So just, I mean, a few more comments about integrated care. So I mean, check if you work for an organization, just check if they have any type of integrated care model in place. And if not, I mean, there are different tools, and you can email me for those tools if you want. I mean, there's a bunch of integrated care practice assessment tools that you can use in your organization to start creating this kind of model. Of course, I mean, technology is improving, and we have a lot of personalized precision medicine in the Hispanic communities. And I think here, for example, University of Pennsylvania is a pretty good research warehouse. I mean, it's a pretty good powerhouse of biomedical research and clinical medicine, and it's just the name is that. I mean, there's a lot of genetic and precision medicine that can be used in behavioral health. And I mean, that includes DNA testing, that includes swab testing to see what medication is the best for that patient, for that client. There's a lot of genomic and epigenomic tools and databases that can be used. And of course, I mean, if you're Hispanic, there's a lot of genetic background that is unique to us. I mean, we are pretty good mix of different ethnicities, and these studies have shown that is precision medicine do work for Hispanic communities. And of course, I mean, there is a lot of research issues with Hispanic communities because we don't have a good participation on research projects. And those of you guys that are researchers, I mean, you know this. Hispanic communities don't participate on research a lot. I mean, due to stigma, due to the perception of medicine itself, also because they have multiple jobs, transportation, especially females are usually not available because they need to take care of the kids or they're working and they're multitasking. Or it's not, the research is not provided on their languages, so they do not understand the protocols and cannot participate. So we need to do a better job on that. So another model is it's called culturogram, and this one is to help staff to recognize the cultural differences between families. And again, culture defined as the thoughts, idea, behavioral, customs, values, skills, language, and religion of this community, and it's based on the family. And each member of the family has a different value, and we see that. I see that a lot when you have immigrants that immigrated with the family, and you have grandma, you know, that do not know the language, have different background or education levels, and then you have mom and dad with different background, maybe understand English a little bit, and then you have a child that speak English pretty well, and that create is a lot of differences between different generations of the family. So cultural gram help you to understand this, and by completing the cultural gram, staff develop a better understanding of the family needs and a better understanding of the client or patient needs, and also help to empower. I mean, discussing this with the family, empower the family by leading to appreciation and the celebration of those unique, I guess, backgrounds or qualities of that family. So just to give an example, this is a cultural gram from a family. Let's see. Sorry. So you have the family in the middle. I mean, George, Maria, Carl. I mean, you have the ages, and then you have the different domains, the reason for relocation, values about the family, values of education, work, health, and you can see how different they are depending on the ages of the family members, how different they are. And of course, I mean, even if you have people from Puerto Rico, I mean, depending where you were born in Puerto Rico, my example of my family, I mean, it's from Vieques, you will have a different perspective of mental health in Vieques because there are no psychiatrists in the island, and there's no even a hospital in the island at this moment, versus someone from San Juan, which there are a lot of psychiatrists and there is a lot of hospitals. So the perspective of mental health and health in general changed a lot. So yeah, they speak Spanish, both of them, but special events, reason for the values about the family, how beliefs are totally different. Um, if you have a family that is mixed, for example, which happen a lot here in the US, that you have a Puerto Rican married with a Dominican having kids, or someone from Central America marrying a Puerto Rican or marrying someone else. I mean, you had those values and affiliations mixed out. I mean, doing a cultural gram like this will help you a lot. So another model to decrease barriers on your patients by understanding the background of each member of the family. In terms of staff, I mean, there is a multidimensional model for developing cultural competence in staff, and you can divide it on individual staff level, clinical program level, organization, which is the organization in general, and create how they see different type of backgrounds. For example, we see a lot of African Americans, a lot of Hispanic, we see Asians, Arabic clientele and patients. So we do this with all racial and culturally a specific patient, and and talk about the different attributes and skills of these different clients, and divide it on cultural awareness, cultural knowledge of behavioral health, and cultural skill development of our staff. So another tool, and you can find this on tip 59, which is improving cultural competence from SAMHSA, and you can download this completely free. I mean, the tips are free. You can go to the SAMHSA website and download the PDF. You can even order a physical book if you like that better. So I work for APM, which is Asociación Puertorriqueña de Marcha, so I'm a big fan of APM. So a little bit about us and the theory of change, which is related to what we talk about here on on a cultural and a multi-dimensional model of developing culture. So we see the individual, the child, and of course the neighborhood, which is the community base. And this is our theory of change, ABM theory of change. So that's why we have foster homes. That's why we have parent training, and that's why we have behavioral health. But we also working on a lot of counseling, especially finances and supportive housing, which are key to have a good mental health. Living in an area that's safe for you, that you feel safe for your family, and 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 you can go outside your home. I mean, it's really important. I have a lot of experience with anxiety and trauma focused therapy, and most of the trauma is they happen in the same neighborhood. I mean, there's gun violence, there's drug use, some people selling drugs on the corner. I have patients that need to, every time that they wake up in the morning, they need to go outside with a bucket full of water to wake up, the homeless and people outside intoxicated on drugs outside so they can get out of their homes. So if we don't have that neighborhood and a comprehensive planning and affordable housing and development or transportation in the area, it's really hard to treat mental health. It's really hard to have someone healthy. So that's why it's really important to have a theory of change that includes not only the patient, but also the family and the neighborhood. When we talk about family, it's really hard to have a healthy relationship with your partner if you guys both feel depressed. Treating one will help the other. So that's why it's really important to talk about family, and as a family history is really important. And even if you're not related to that person, but it's in the same house, I mean, it's really important to talk about mental illness and also invite that patient or that family member to treatment and be part of the treatment as well. There is a lot of new health resources out there, behavioral health resources, especially now in 2024, and acceptance. I think it's the acceptance of mental health and people talking more about it. We see a lot of people that, I mean, their job is entertaining, and a lot of athletes talking about their own mental health, and singers, right, and people that are popular talking about it and social media. So I think that's helping in some level. It's the term is okay not to be okay. It was I think that was a big marketing out there. Also, the Me Too movement in terms of trauma and things like that. I mean, it's their movement that has created a lot of attention in terms of on treating mental health and treating abuse and trauma. I mean, some examples are habla ellos escuchan, which is talk. That's for kids and the alcohol use. There's SAMHSA have a really good pamphlets and information out there that's completely free that you can download. Of course, the 9AA and the suicide prevention resources that they have created, and it's pretty new. And SAMHSA have a lot of resources for and NIDA too. I mean, all these stake, I guess, federal organizations have a good resources, and they're trying to have it in Spanish too. I say they're trying because most of the resources out there, at least in these organizations, are in Spanish too, and that have been, it's pretty new. I mean, it's not. I mean, it's been around probably for a couple of years, no more than 5 years, that these resources are in Spanish. So look for them. Look for them. I mean, these are other organizations that I'm familiar with. I have some grants with NIH in terms of minority health and health disparities. So they're pretty good resources. In terms of Puerto Rico and other organizations, I mean, there's some good nonprofit that, I mean, they do good work and webinars and education resources for mental health, people with for educators and people with mental illness in Puerto Rico. So that's another example there. In terms of governance recommendation, I mean, these are some staff recommendation I can give you guys. I develop local outreach and education programs in multiple languages for your staff member. Peer support programs, having presence of community housing events and developing partnerships is really important, and helping the at different levels, the community at different levels. So again, with Augusto, we talk about the observations. I think it's a good candidate for the cultural ground that we talk about. And here, recent protective factors. We talk a lot about this. I mean, community, family, school, peer, individual. So it's good to divide them and to understand the patient and their families. Different states have different programs, recovery support, recovery high school, college recovery program, faith-based organization, 12-step young people groups that are available depending on the state. And there's a lot of new opportunities to build resilience in our kids. I mean, trauma-informed approaches, social emotional learning, and a lot of social apps, and they're pretty good and are, pretty good in terms of information and locators. For you can put your zip code and they locate treatment for you and services for you in the area. So I want to have some time for questions. So thank you for your time. I know it's a lot of information and I wish I had more time, but I want to open the floor for questions.
Thank you so much, Dr. Colon, for this insightful presentation. We do have some questions that started to come in. One of them reads, what recommendations would you offer when, as a provider, you do not share the same culture and language of your clients?
That's a great question. And I'm guessing we recommend a lot of peer support and mentorship programs. I mean, we have most organizations like American Psychiatry Association, the AAAP, which is the American Academy of Addiction Psychiatry. They do provide mentorship, and I think it's a good way of having someone, to talk about this case or cases that you have. And if you don't understand the language and you don't understand the culture. Also, I mean, outside, I mentioned a few of the organizations that have good data, and they have trainings for free that you can take to get more information and, prepare yourself to be more cultural humble, more cultural competent for those clients. In terms of language, it's kind of hard to learn that second language if you don't have the time, but I mean, there's a lot of apps that you can try. And yeah, so I think a peer support program or a mentorship program will help.
Thank you. And so we also have here one question from Martha Alanis. Is there any nonverbal strategies that we can teach families to integrate in the home when there is barriers of language? There is a cultural generational gaps that become barriers, and many grandparents raising grandkids that I believe can use support. I use the app Google Translation to have them play games together and have them practice being present.
That's good. Board games is another one that we use a lot. When we do something called play therapy, and we include all the family. There's some cards that are emotional cards. I'm forgetting the right name for those, but they do help because they're pictures only. They're picture or infograms that people can share their emotions by showing a happy face, a sad face, or other emotions that are available in this card. So if you send me an email, I will send you. There's a few companies out there that use that kind of observe a tool, right? And then probably there are apps as well that you can use to communicate.
Thank you so much, Dr. Colon. I see. Maybe we have a few and many comments, many thank yous to you for the work that you've done. I have one in Spanish that I'll do my best here to translate. Which I would like to know which one do you think is the best strategy um, to get interest from Hispanics into services and programs? Maybe this in terms of what you had mentioned, the perceived need of care. Um,
So yeah, I mean, I think we need to normalize mental health, and that's hard to do in the Hispanic community because we don't do that often. I mean, normalize mental health and substance disorder in terms of it can happen to you, and it's happening to you, and probably you have a family member that had uh, substance disorder and mental illness. I see a lot of Hispanic patients, and when you ask about family history, they usually say no. But then when you are with the mom and dad in the same room, you see their heads like saying, yes, me too. So there is not a lot of talking about it in their families. So one, increasing family therapy, including the family in the treatment of the kids or any adults, is important. Talking about it in the house, right? I recommend you guys to talk with your family members about substance use or mental illness in the family. That's really important. So we need to normalize that. Also in social media, I mean, a lot of influencers. I mean, I'm okay with following influencers that talk about their mental illness to know that it can happen to anyone, and acceptance that. Um, in terms of looking for help, is it's tricky, could depend on where you live and if they have the services. But with telemedicine and telehealth, I mean, it's and calling your insurance. I mean, sometimes we don't think about that. Calling your insurance, they can link you with a provider. Also, if you go to samhsa.com and samhsa.org, you can find they have a locator of services, and you can actually put your zip code, and they will give you a list of providers close to you that you can go to.
Thank you. That is such resourceful information and insights that you shared. We've really been delighted to have you, Dr. Golong, throughout today's presentation, and we thank everyone who has joined. Just to let everyone know in the audience, we've shared those links to the evaluation, so you can give us your feedback in terms of trainings and other products and services in terms of workforce development for you as providers that you might want to see. And with that, I think we'll be wrapping it up for today, but stay tuned for future events of our center. Thank you, Dr. Colon, and thank you,
Yeah,
everyone.
and if you want to share my information, feel
Oh,
free to
okay.
do that. I don't know how to get my information out there. I mean, the chat is pretty active, so if I put something, I would lose it pretty fast. So,
I
so,
know.
so if there's a way of doing that, or if you guys can contact the Hispanic Latino Behavioral Health Center of Excellence, I mean, you have the email there and the website, and they probably can connect you guys with me or something.
Yeah.
Also, if you go to the Opioid Response Network, which is ORN, the Opioid Response Network, you can ask for a consultant, and it's completely free for you guys. So if you're looking for someone to help you to create a structure on your clinic or talk about or give a talk to Hispanic communities or to hospitals or clinics, go to Opioid Response Network, and they will help you. And you can ask for me if you want to as a consultant, and it's completely free for you guys. So again, Opioid Response Network or ORN, you can Google that, and you will find the link and the website.
Thank you. And that's a very important resource which we collaborate with too, and focuses again on those peer recovery support networks as well. And as Dr. Colon mentioned, those services and consultations and trainings are free to your agency. So if you have an interest, please go to ORN or to our center as well to request free technical assistance and training. So this has been wonderful to hear and to share with all of you. And we'll hope to see you soon again. Thank you,
Of
Dr.
course,
Colon.
anytime.
Thank you.